8 o'clock is 4 minutes away from now. So we will hopefully start in right time, right? So first participants is Dr. Paridhi. You are here? Okay, we'll call you in time. Okay, fine. Yandas, I'm a senior consultant in Arvind Eye Hospital, Madurai, and all of the judges, they will introduce themselves.
I'm Dr. Aditi Patwardhan. I'm a vitreoretina surgeon. I'm a fellow from SIRS Place only, Arvind Madurai. Currently, I'm practicing in Pune.
Hello everyone, I'm Dr. Sonal Kalia. I'm Assistant Professor at SMS Medical College, Jaipur. I'm also associated with the Young Ophthalmology Society of India in the capacity of being its Vice President currently. So I hope that some of you would want to join the activities there also in Biopavilion today.
Good morning. I'm Dr. Shilpi Narnavre, vitreoretinal surgeon and ROP specialist from Nagpur. All the best to everyone.
Good morning. I am Dr. Paridhi, here to present a case on suspected focal frosted branch angiitis due to a retained metallic intraocular foreign body. Frosted branch angiitis is the name given to the retinal vessels because they resemble the ice-covered tree branches also seen in CMV retinitis, but it is not only typical to CMV retinitis, it can also be seen in immune-mediated reactions to infections, inflammations, neoplasms. What is interesting to note is that it has also been reported after blunt ocular trauma, traumatic endophthalmitis, and after extensive literature review, we found one case also reported in a retained intraocular foreign body. Our 35-year-old male presented with a left eye complaints of a painful loss of vision since 2 days. He gave a history of trauma to the eye while hammering an iron bearing, wearing no protective glasses. He had no viral prodrome, previous systemic or ocular complaints. On examination, the right eye was 6/6 vision and examinations were normal. In the left eye, however, vision had come down to perception of light and projection of rays accurate. Conjunctiva showed congestion with a focal superonasal hemorrhage. Cornea was clear, but the lens showed early cataractous changes. On dilated fundoscopy, we found dense vitritis with inferotemporal preretinal hemorrhage. We investigated with a USG scan, and this peak on the USG A corresponded to the USG B hyperechoic area anterior to the retina, suggestive of a retained foreign body surrounded by vitreous hemorrhage, which was confirmed on X-ray, which showed a single small metallic foreign body. So after a negative serology and blood workup, we started him on topical antibiotics, steroids, and cycloplegics. And the patient was planned for a 23 gauge pars plana vitrectomy to clear the vitreous hemorrhage, after which we could visualize the metallic foreign body. And interestingly, beside it, we saw what seemed like frosted branch-like vasculitis. So after laser around the foreign body as well as the entry site in the temporal area, in the nasal area, we gave a PFCL cushioning and retrieved the foreign body with a handshake retrieval technique, and silicone oil tamponading was done to close the case. Vitreous specimen was sent, though it was negative. Patient was started on oral antibiotics and steroids, which were tapered over 6 weeks. So this color photo shows the 1 week follow-up, which shows the laser marks, but complete resolution of the perivascular exudation, which appeared to be frosted branch angiitis. The same blue autofluorescent image of the same area shows that the silicon oil is in situ, seen by the artifact. the retina is on and there is no recurrence of the vasculitis. So what we want to highlight is that frosted branch-like vasculitis can be caused by a number of entities, and it is basically due to an intense inflammatory reaction. We hypothesize it is due to plasma kallikrein released due to hemorrhage, breakdown of the blood retinal barrier following trauma, as well as the presence of a foreign body. The fact that there was no underlying predisposition that this patient had for a frosted branch vasculitis and the temporal association between removal of the foreign body and resolution of the frosted branch angiitis further supports our theory. What we can do to go a step beyond is a metallurgic study of the metallic projectiles to know which specific metal causes this reaction acting as the antigen. My take-home message is that prevention is better than cure. We should make the patient aware that safety glasses are to be worn while operating power tools. You snooze, you lose. Early removal can prevent extensive damage to the vascular and ganglion cell layers of the retina. But better late than never, because late removal will still prevent chronic degenerative changes. And slow and steady wins the race. After ruling out any contraindications, long-term steroids to prevent or treat the complications of a metallic foreign body should always be considered. Thank you.
Thank you
was
for
nice.
finishing on time.
It was a nice presentation.
Thank you, ma'am.
Yeah. So we can, any questions from the judges?
Thank you, ma'am.
So just a question, one question, Paridhi, and that I wanted to ask you. So what is the wound entry wound? At which level it went?
So it was superonasal, and the foreign body was seen lying inferotemporal, as in the fundus photos that
Okay,
we
it was
took
not
for
to the
follow-ups.
cornea. It was not to the cornea.
Not through the cornea, so it
It
was
was sclera.
scleral, which was covered by a subconjunctival hemorrhage when the patient presented.
Okay. Another thing, did you give any intravitreal treatment during the surgery after removal of this thing, posterior segment?
So we did a IVT-assisted PPV, but apart from that, we did not give antibiotics intraoperatively. We started him on topical, and after cultures, it was negative. So we were not expecting an endophthalmitis,
Yeah.
but
Actually,
oral ciprofloxacin 750 was given, sir.
okay.
BD.
I think most of the cornea retina consultant here will agree that any intracorneal foreign body, when removed by any means, the posterior segment should be fortified with medicines.
Yes,
So we
sir.
have brought a medicine, this foreign body through the vitreoretinal posterior segment approach to the anterior segment, and then you have taken from handset technique. So that means the two compartments are already
Can be
involved.
contaminated. Yes, sir.
Okay. Okay, thank you.
Excuse me, one more question. How long you give the steroids, oral steroids?
So, ma'am, 6 weeks. We gave it for 2 weeks at full dose, 1 mg per kg, and then we tapered over 4.
Next speaker is Dr. Anshu Kita. Is she present? If the AV people could help her out, please.
Good morning, everyone. I'm Dr. Anshu Kita, presenting 2 cases on bilateral presentation of high voltage electric current induced cataract. So, high voltage electric burns can lead to varied range of injuries and even death in certain scenarios. The resulting ocular injuries can have manifestations in form of conjunctival hyperemia, corneal opacities, cataract, uveitis, choroidal and retinal involvement, and can involve optic nerve as well. Out of these, electric cataract can occur after a period of latency, and they can progress with a startling rapidity. So, electric cataracts tend to be bilateral and are uncommon, but exclusive involvement of lens with sparing of other ocular structures is even rare. Here we present two such cases, in which the first case is of a 20-year-old Indian male who presented with us with complaints of painless, gradual, progressive diminution of vision in both eyes, more in right eye for 6 months, and there were no other ocular complaints. There was a history of electric shock from live wire 1.5 years ago with multiple electric burn marks, with loss of right toe as well. The entry and exit wound are shown in figure in the right shoulder and left thigh respectively. There was no any history of trauma or previous ocular surgery or any systemic illness. Here we can see the multiple exit wounds as well and the loss of right toe. On ocular examination, the right eye BCVA was hand movement with accurate PR in all quadrants, and left eye was having 6/60 vision, not improving by pinhole. Both the pupils were normally reacting to light and AC was quiet, but right eye showed white mature cataractous lens with left eye lens showing anterior capsular and cortical cataract. On IDO examination, right eye showed no view of fundus, with right eye B scan also showed no remarkable finding. Left eye fundus was also within normal limits. All the other ocular examinations were within the normal limits, and the systemic examination also were within normal limits. So we proceeded with the management with right eye manual SICS with PCIOL under LA, followed by same procedure in left eye but after the 2 months. And follow-up vision was satisfactory as shown, and in picture as well we have the post-operative picture. The second case was more of an incidental finding, where a 30-year-old Indian male visited our department with right eye corneal injury with a broken pipe while working. On ocular examination of right eye, we found a visual acuity in right eye of hand movements with accurate PR in all quadrants. Lid and showed no abnormal finding. Conjunctiva has congestion and grade 1 nasal pterygium. Cornea showed a linear corneal tear measuring 3 mm present in center of the cornea. Pupil had no RAPD and was normally reacting to light. In AC, we found whitest lens matter in AC with a reaction, and AC also showed reaction of 3+ and flare of 3+. And also on examination, the anterior capsule of the lens was breached. So while on examining left eye, it was of a sheer surprise. The visual acuity of left eye also was counting finger at 1 feet with accurate PR in all quadrants, with no history of trauma in left eye. The lid, adnexa, conjunctiva, cornea, pupil, and AC had, the examination was within normal limits. When we examined lens, we found anterior subcapsular cataract in left eye as well. So we elicited retrospective history, and the patient gave no history of trauma in left eye, no history of any ocular surgery in left eye previous, but he gave a history of high voltage electric shock with live wire 3 years ago. So we did a complete systemic examination, and we did find entry and exit wound on scalp and left forearm respectively. So we did all the investigation systemic which were within normal limits. So we proceeded with the management of right eye corneal tear repair with lens matter aspiration with PCIOL implantation under LA under guarded visual prognosis. Later on, the left eye was also operated with manual SICS with PCIOL under LA, and the follow-up vision was for right eye it was 5/60, and for left eye it was 6/6 partial. So we have these post-operative pictures of the right eye and the left eye. So my take-home message on these two cases will be that electrocution is a common occurrence in country like India, where we find high voltage wire hanging over our heads on electric poles and electricians working without proper protective gears. Electric cataract tend to have a latency period, and they progress at a staggering speed. So they are usually bilateral and are rarely reported. So but on proper surgical management, we have obtained good visual results as shown in many papers. though it is a very rare finding. So the final visual outcome may depend on other ocular damage as well, because other ocular damage can be there and it can lead to death also. So like if no ocular damage is there, only cataract is there, these have shown great visual acuity after post the cataract surgery. That's all about my presentation. Thank you.
The fundus examination was normal.
Yes, ma'am. In both the cases, we did fundus examination, and that was normal. We did actually in one case, fundus was not visible because it was this is the lens status. So we did a B scan, and it
No,
was.
post-op I'm asking.
Yes, ma'am. Post-op we found normal.
To
fundus
be very
examination.
clear regarding your second case, the bilateral, which you're labeling it as bilateral,
Yes,
so
ma'am.
there was a corneal tear and there was a breach in the anterior capsule,
Yes, ma'am.
right?
Yes, ma'am.
And the injury for the electric was old.
Yes, ma'am. It was.
Am I right?
older.
So how
Yes,
can you
ma'am.
label this as a bilateral cataract now?
Because,
You cannot actually.
Actually, ma'am, I would my points in my favor would be that it was an incidental finding, moreover, because it was just a pipe injury, and he presented with very early, like right after the trauma. He was a worker in our own college only. So, and also since when we asked the history, he told that he was having diminution of vision in both the eyes, but it was like his daily works were not being hampered, so he didn't care to visit our OPD. So on right eye, it was there, like when we examined the left eye, also the other eye, the cataract was present, and visual acuity was also low. So on retrospectively, we elicited the history and other things. So then we concluded that the cataract might be present there, and since it is anterior capsular as well and cortical as well, the trauma might have brought about the injury in the lens matter, and it might have breached the anterior capsule, but the cataract might be present beforehand, because based on our retrospective history and examination, we and patient whatever patient told, based on that.
What about the cataract status in other studies? Is it
Yes, ma'am. In other studies, mostly they have found anterior subcapsular cataract, though the presentation, it's like very rare, and it's rarely reported, because many patients also have mild cortical cataract, but mostly they have found it to be anterior subcapsular cataract or anterior capsular cataract.
symmetrical or asymmetrical?
It might not be symmetrical, because many patients have presented like of severe grade in one eye. Means it starts at starting it's very slow, and when it starts to progress, it's progress at very staggering rate. So it might be asymmetrical as well, because in one patient, my first patient, one eye had mature cataract and the other eye didn't have mature cataract. So in our case only, like both the findings were there. So
Okay.
thank you.
Thank you.
Can we please have the next speaker, Dr. Harish Elango? Is he present? So the next speaker is Dr. Anup Kumar Goswami.
Good morning, chairpersons and dear friends. I shall be presenting a rather unusual case of isolated partial irisostromal tear in a case of blunt trauma. A 29-year-old male presented to us with redness in the right eye following blunt trauma. I don't know why it is jumping. And there was no history of any previous recurrent red eye trauma, any treatment or systemic illness. Best corrected visual acuity was 6.6 in both the eyes. Torchlight showed I don't know why this is periorbital ecchymosis inferiorly with subconjunctival hemorrhage with normal pupillary reactions. Slit lamp examination showed few fine pigmented keratic precipitates on the cornea with normal anterior chamber. Now the right eye iris showed a cleft of 1.5 to 2 millimeter long at 8 o'clock hour in ciliary zone merging with a crypt. That was 0.5 millimeter away from the root of the iris with partial splitting of the stroma. And as we can see here, yes, and there was exposed whitish collagenous tissue with no transillumination defect. The left eye was normal without any altered iris configuration. Intraocular pressure, gonioscopy angles and fundi were normal. So a diagnosis of isolated partial iris stromal tear was made and patient was started on moxifloxacin eye drop and advised monthly follow-up after 10 days of treatment. Literature was reviewed and a diagnosis was reaffirmed. As we all know, blunt trauma to the eye ranges from simple subconjunctival hemorrhage to serious lesions like choroidal or retinal rupture and or a globe rupture, and it has been found to be a major mode of injury in South Indian population. The precise mechanism of intraocular damage following contusional injury to the eye is not well understood, although the damage can be attributed to equatorial distension of the globe following anteroposterior compression. Now, many iris abnormalities are found following injury, which can be seen here, but none was found in our case, like iridodialysis or pupillary sphincter tear. Why this is going? I don't know. Yes, and then iris atrophy causes stromal thinning of and with loss of crypts, altered surface texture, and presence of transillumination defects. Diffuse or segmental atrophy following inflammatory disease are also seen in certain cases, but none of these features were found in our case. Then prominent crypts of Fuchs are described as normal variants, are diamond shaped with preserved adjacent iris structure, and they are multiple around collarate or sometimes peripheral close to the iris root. So in our case, preserved iris texture adjacent to the cleft and normal left eye configuration excluded congenital defect clinching the diagnosis. The isolated partial stromal tear is unknown, and explanation for such a presentation in our case is probably a young age and robust tissue strength which prevented a full tear. Then the indirect blunt trauma in that particular case was probably in the same clock hour with, as we can see from the subconjunctival hemorrhage, and that prevented a kind of a tear in other parts of the iris, and patient was advised follow-up for possible development of iridocytosis and glaucoma. To conclude, the case emphasizes a need for cautious assessment of ocular structures on initial presentation. Whitish appearance of exposed collagenous tissue can be misdiagnosed as iris atrophy on cursory examination, and both eye examination under magnification is crucial for correct diagnosis. Thank you.
Thank you, Dr. Anup.
Yes.
So it's a good presentation. But you said this eye is a blunt injury.
Yes.
What type of blunt injury it was?
It is a road traffic accident.
It was a road traffic accident. How did he got it?
He fell from his bike.
Down
Mobile.
to the
Yes.
down to the this thing. Okay, in the floor or this
Yes.
road only.
Yes, road.
Okay. So with this, you have already told there are many normal variants
Yes.
of iris atrophy, and your specificity on that point of iris atrophy. How did you confirm and did you dilate it?
Yes,
Did you
yes.
do a transillumination test
Yes.
to know?
We did a retillumination test on the slit lamp also.
Did you dilate it?
Yes, we did a complete examination.
No, why I'm asking is that
Yes.
if you get a blunt trauma with that sector of temporal this thing, and you get a corresponding hemorrhage, which you only validate because you get a subconjunctival hemorrhage at the same place
Yes.
where the iris atrophy is there, and then isolated one spot, I personally feel may not be due to trauma at all. Because you see, unless you dilate it, unless you see the iris imprints of iris pigments on the antral lens capsule, you just to extrapolate data from dew color, you cannot say that it is due to trauma. With that one, that is why I'm asking this question: that how do you validate your findings?
See, the point is that it can never be validated by any kind of a data, and these some things are always diagnosed first time. So this is what we feel. This is our hypothesis. This is not that
Hypothesis, yeah, right.
exactly.
Yeah.
This is not we. It cannot be. It can be only hypothesized because this is what possibilities. Because there is no other similar deep crypts, no other similar findings in the other eye. So what is the possibility of this being a kind of a resulting from trauma? So this is what is the possibility we are discussing. This is open to suggestions and criticisms and.
No, it's not criticism.
No,
It is-
I mean, kind of suggestions and
Yeah.
discussions. We learn by that.
Yeah, with that much of trauma, if you get an iris this thing, I would expect some anterior segment changes, at least in hyphema or little bit.
See,
this thing.
another reason which I think is
Some
because
dialysis, something like
the impact probably was saved from the by the orbital rim. That probably absorbed some part of the impact, and the impact, the only a partial impact happened in that particular zone, that particular clock hour. So result, and patient being young, so the iris probably was strong enough to withstand that kind of a trauma. So only a partial tear happened, and maybe it was continuous with a crypt, which that crypt got extended. This is all the possibilities are there.
So how long you want to see the patient after
At
the
least
injury?
3 to 6 months. That's
3 to 6 months are enough?
see.
for-
Unless we see 6 months is good enough a time for anything else to happen. Even if we consider of angle recession or any other retinal problem or kind of 6 months, we feel that unless the patient is having us kind of any harbinger of any kind of a change, 6 months is a good enough time. Thank you.
Thank you.
Dr. Soumya Shri.
Good morning, everyone. I'm Dr. Soumya, and I'll be reporting a case of traumatic hyphema in a hemophiliac child. So, hemophilia A, also known as classic hemophilia, is an X-linked recessive disorder caused by the deficiency of factor VIII. It is the most common type of hemophilia, affecting around 1 in 10,000 males worldwide. Traumatic hyphema refers to the accumulation of RBCs in the anterior chamber, most commonly following blunt trauma to the eye. Medical management in a case of traumatic hyphema includes topical corticosteroids, topical cycloplegics, and topical anti-glaucoma medications. Surgical intervention includes AC paracentesis with peripheral iridectomy or trabeculectomy. So this is a case of 6-year-old male child who presented with diminution of vision in right eye following blunt trauma 12 days prior to the presentation. The child has a known case of hemophilia A since 8 months of age. On examination, the vision in right eye was PL positive with accurate PR. Anterior chamber showed total formed hyphema with a fibrinous clot superotemporally. There was diffuse corneal endothelial blood staining with microcystic edema, and the intraocular pressure was found to be 34 millimeters of mercury. B scan showed vitreous hemorrhage. The other eye findings were within normal limits. So we started the child on tobramycin 0.3% eye drops, homatropin 2% eye drops, and we got glaucoma evaluation done, and we started the child on dorzolamide 2% eye drops. Cornea evaluation was also done, and the child was advised to undergo right eye anterior chamber paracentesis with clear corneal incision with intracameral triamcinolone and air bubble to be injected just before the closure. Accordingly, we did investigations, and the child's factor VIII level was found to be 7%, which is very low. APTT was prolonged. INR was also raised. Therefore, as per pediatrician and hematologist advice, fresh frozen plasma transfusion of 15 international units per kg was started. We gave a start dose of 750 international units followed by 375 international units 12th hourly for a week. So after 1 week of transfusion, vision was PL positive, PR accurate. Intraocular pressure had reduced to 18 millimeters of mercury. Hyphema had also subsided, sparing the fibrinous clot which was in the superotemporal region. There was 1+ reaction in the anterior chamber with endothelial staining. Mydriasis was present, posterior synechiae noted at 1 o'clock position, iris atrophic patches were present, lens was cataractous, and indirect ophthalmoscopy showed vitreous hemorrhage, and we asked the child to continue the same treatment. Thus, the hyphema had resolved with conservative treatment, avoiding the surgical intervention. 1 month follow-up, vision in the right eye was hand movement positive, intraocular pressure was 14 millimeters of mercury, and anterior chamber was squared. Rest of the findings was similar. At 3 month follow-up, the child had developed esotropia in the right eye with vision of counting fingers at 2 meters. Intraocular pressure was 14 millimeters of mercury. There was traumatic mydriasis with iris atrophy. Posterior synechia was noted at 10 o'clock and 1 and 2 o'clock positions. There was a fibrinous addition present at 10 o'clock position. Ectopia uvea was present. Lens was cataractous. Iris pigments were present on the anterior capsule. And there was subluxation noted from 3 to 5 o'clock position with phacodonesis. There was vitreous hemorrhage had resolved, and there were RPE alteration. Rest of the findings were normal. So we sought the pediatric ophthalmology opinion, and the child was advised to undergo right eye cataract surgery with fourth row pupilloplasty, but the parents refused the surgery. At present, like 1 month before, the vision in the right eye had improved to counting fingers at 3 meter. Intraocular pressure was maintained. Traumatic mydriasis and subluxation was present with cataractous lens. CDG Morsman et al. In a case of traumatic hyphema in a 9-year-old boy with hemophilia A reported that factor VIII transfusion has to be started immediately even if there are minor signs of intraocular hemorrhage. Whereas Selman Belvirani et al. In a case of traumatic hyphema in a 16-year-old boy with severe hemophilia A reported that early clot removal could be done along with factor VIII replacement, and also in the post-operative period we have to continue the same for about a week. In our hemophiliac patient, although surgical management was initially planned, traumatic hyphema resolved with just factor VIII transfusion, annihilating the need for surgical intervention. So to conclude, the normal factor VIII level is between 150 to 150%. Our child had 7%. Traumatic hyphema usually resolves with conservative management alone. Early initiation of factor VIII transfusion is the need of the hour in hemophilia patients presenting with traumatic hyphema. If any surgical procedure is planned, factor VIII transfusion is required during the procedure and has to be continued post-operative period as well. These are my references. Thank you.
Dr. Soumya, very nice presentation.
Thank you, sir.
And anyhow, you are a ratified and non-ratified person, so we are not going to give you any marks. But it was an eye-opener for all of us to learn. And I think the main this thing is that history. So anyone can come with a similar present of trauma. So this hemophilia patient, did you discover it, or the patient so moto said that I am a hemophilia patient?
A known hemophiliac, sir. At 8 months of age, the mother noticed that the child had swelling in the knees. So when he was taken to the doctors, there was hematorosis, and he was diagnosed with hemophilia A, sir.
Yeah, then it's fine. Good presentation.
Thank you, sir.
So can we have the next author, please? Dr. Pradeep Kumar Chandane. Is he present? Dr. Apeksha Kataria. Dr. Ashwini Kurane. Dr. Ria Majumdar.
Good morning, everyone. I'm Dr. Ria Majumdar, and I'll be Good morning, everyone. I'm Dr. Ria Majumdar, and I'll be presenting a study on intraocular foreign body injury in children and the factors associated with endophthalmitis. Intraocular foreign bodies are present in almost 40% of all penetrating globe injuries. Visual prognosis usually depends on the zone of injury, type and size of foreign body, and the subsequent complications associated with it. Here we can see localizations of different sorts of intraocular foreign bodies. This is a corneal IOFB, this is a lenticular IOFB, and this is a intraocular foreign body lying on the retina. And here is a USGB scan with showing associated retinal detachment. The clinical history and examination in these patients is very important. Localization of IOFB is usually done using appropriate imaging techniques. Sweet localization technique can be done in these patients to gauge the zone of injury and the location of the IOFB. Management usually is consisting of appropriate antibiotic coverage and appropriate surgical management, Associated complications like retinal or choroidal detachment and endophthalmitis can be managed accordingly. The risk factors for endophthalmitis in these patients are organic IOFB, delayed removal of IOFB, posterior open globe injury, traumatic lens injury, and contaminated settings of surgery. This is a retrospective, institution-based retrospective case control study showing in which we studied 100 patients aged less than 20 years diagnosed with globe injuries with IOFBs. We wanted to study the clinical profile of the IOFB injury in children and the factors associated with endophthalmitis. This is the demographic profile of the patients. Males were more commonly affected than females. The age distribution showed maximum IOFBs being present in the age groups of 5 to 10 years of age and 10 to 15 years of age. The type of IOFB found was most commonly metallic IOFBs, and the most common cause of injury was firework injury. In males, metallic IOFBs were more common, while in females, vegetative IOFBs were more common. 12% of these patients were diagnosed with post-traumatic endophthalmitis associated with IOFB, more commonly associated with vegetative sort of IOFB, and with delayed initiation of treatment, that is more than 1 month. Zone 2 injuries were more commonly associated with endophthalmitis. Associated ocular features like uveal prolapse, traumatic lens injury, and retinal detachment were more commonly associated with endophthalmitis. The take-home points from my presentation were: the clinical profile of IOFB injury in children is a little different from that of adults, metallic IOFBs being the most common foreign body. More common in males is metallic foreign bodies, that is due to firework injuries, while vegetative is more common in females. Vegetative IOFBs are more commonly associated with post-traumatic endophthalmitis. Zone 2 wounds are more commonly associated, while associated uveal prolapse, traumatic lens injury, and association with retinal detachment are all risk factors for endophthalmitis. Conclusion: open globe injuries in children may be associated with presence of IOFB, which is most commonly metallic in nature. Appropriate clinical evaluation and early management are necessary to prevent post-traumatic endophthalmitis. Thank you.
Very well presented. Dr. Joglekar Mandar Atul is here. Mandar, sorry.
Good morning, everyone. So I'm here to present a retrospective comparative study of the outcomes of the iris saving procedures in the corneal tear management. So iris abscission in the management of iris prolapse is considered as a necessary and essential procedure in all cases. However, it leads to irregular pupils, loss of pupillary reflex, photophobia, and aberrations, which further reduce the already compromised vision and leads to reduce the quality of vision as well. So can we safely avoid the iris abscission and save the iris? So we did a retrospective analysis. We included all penetrating injury cases between November 18 and March 21. All zone 1 injuries with plus minus zone 2 extension were included. Iris prolapse should be at the presentation was an inclusion criteria. We excluded all cases of follow-up less than 3 months, cases of IOFB, zone 3 involvement, and primarily zone 2 injuries. Next. So we divided these cases into 2 groups, group A with iris abscission and group B with the iris saving procedure without iris abscission. We records analyzed for demographic data, mode of injury, time interval at the presentation, presence of the lens injury, post-op events and procedures, and final best corrected visual acuity. So this is one illustration of iris saving surgery where we remove the membrane over the iris, which we excise either or we peel it off. We'll reposition the iris and we suture the wound. Next. So total 27 cases were there in this period. So out of which 19 cases had iris prolapse, they were included in the study. Group A had 11 cases with iris abscission and group B had 8 cases. This is demographic distribution. The significance concentration was in 11 to 30-year-old males. So trauma since hour and injury zone distribution was not significant. The rate of traumatic cataract surgery was also not significant in the 2 groups. two groups, however, two patients in group B underwent procedure for synechial release, which none of the patients in group A required. The incidence of post-operative infection was 0 in either groups, so no cases of infection was found. The final visual acuity was not statistically significant amongst the two groups. So here we can see that post-operative final outcome of good pupil, round pupil in these cases, which is a functioning pupil and can lead to a good quality of vision even with these tears. So in between the two groups, the visual outcomes showed no significant difference. There was no difference in infection rate, so no post-operative infection was seen. No significant difference was seen in the traumatic cataract formation. However, group B had patients requiring intervention for synechial release. Iris sparing surgery so the conclusion is the iris sparing surgery in the repair of corneal tear gives comparable outcomes as compared to the iris abscission and is non-inferior. Iris sparing surgery is safe and effective in selected cases. In our opinion, the possible requirement of synechial release surgery is offset by the benefit of pupil sparing. As sample size is small, this needs verification by a larger sample or prospective studies. Thank you.
So, Dr. Mandar, nice presentation, but I have got some clarification in this presentation.
Sure.
So, most of the cases you have shown in the iris prolapse.
Yes.
So, this iris prolapse, what is the most common cause in all this injury, mode of injury in all these injuries causing iris prolapse? Mode of injury.
The mode of injury was at the sharp objects.
Yeah.
Basically.
So, why I ask you this question is that.
Not the globe rupture. It's a sharp.
Yeah. Why I ask? Because all of the presentation, whatever pictures you have shown, all appears to be iris cut or iris prolapse or corneal injury without any corneal wound infiltrate.
Yes. Right.
So that may alter your outcome of this surgery.
Yes. As I said, it's a selected cases you can do this.
Okay. And another thing is that even if it is a retrospective study, it appears to be very specific for this type of cases. It is not like you didn't intend to take other cases. You just selected these cases and.
Yes, definitely. That's what I want to convey, that we can do it in the selected cases.
Yeah.
Not in all cases, definitely.
Okay. And another thing I wanted to ask: what is the days of presentation after injury? All these cases. How many days after an average?
Within 48 hours.
48 hours. So that's the catch. So, and why I ask this question is that they decision to take iris abscission or reposition depends on the duration of presentation.
Exactly. Yeah.
So, if you have taken clean injuries, then why do you think that iris sparing is needed or iris abscission is needed? If it is less than 24, is 25 cases or whatever number of cases you have taken, all maximum 90% are less than 10 hours or less than 24 hours, then why do you need to at least
because I'm
exercise
presenting
the
it
tissue?
because most of the still I see the videos and presentations depicting iris abscission in early cases as well.
No, yeah, that the videos and
because
presentations
the
are different,
thing
but
is
Is
that's
there any
the-
literature to support that? Is there any literature?
I
You're
didn't
saying videos are there.
I didn't find.
We don't really validate.
But if you go to any conference, any talks, this is the take-home point is always given that should be an iris abscission.
yeah,
whatever-
absolutely correct. You are saying that iris products should be removed, but that's the duration. That the time of presentation, mode of injury, and the nature of injury is important in selecting the iris tissue excision. It's the tissue which is needed. God has given, not to excise and throw it out. XYZ has done it.
Exactly
doesn't
the
mean
point.
that we are
Exactly the point I want to buttress.
Okay, fine.
Sir, any other precaution in terms of antibiotic use or anything, any extra?
No, nothing extra. It's the same process.
Okay, thank you. So today we have 3 absentees, no, madam? No? 4. Okay. Not there, I have 4, yeah. Yeah. We have got enough time to wait for them. Other they should not complain that by the time I reach, no one is there.
Yeah,
No,
Dr.
take
Harish
while-
Elengo, and then there is Dr. Pradeep Kumar Chandane, Apeksha Kataria, Ashwini Kurane.
We hardly meet each other, but it's so fine. Yeah, yes, yes.